started your timer and here is your question. Right, so if you have read and understood, considering the surgical and optimization, kindly tell me if you can identify this structure. What are you looking at?
This is the image of the liver from the inferior posterior part of the liver.
Okay. Right. Can you please tell me if
Also
you can...
called as the visceral portion.
Very good. Okay, can you please identify the structures which are encircled? 9, please.
Yes, ma'am. Number 9 is the gallbladder. Number 5 is the common hepatic duct. Number 11 is the hepatic artery. 20 is the portal vein. Number 13 is the inferior vena cava. Number 2 is the quadrate lobe of liver. Number 17 is the ligamentum teres and falciparum. And number 20, one is that's the one.
Where is one? Okay, don't tell me the ones which are not labeled,
Yes,
just the circled ones, red ones. Did you tell me what
yes,
15 is, please?
15 is the left triangular ligament, ma'am. 25 is the right triangular ligament.
Okay. How many triangular ligaments are there which are supporting the liver?
2, ma'am, right and left.
Okay. Can you please tell me what are the parts of the liver?
There are 2 lobes, the right lobe and the left lobe.
How the right
Hello?
and left lobes are divided, both anatomically and surgically, please?
Ma'am, anatomically they are divided by the falciparum ligament, falciparum ligament anteriorly, and posteriorly the ligamentum teres and ligamentum venosum. Functionally, they are divided by a plane from the gallbladder fossa to the inferior vena cava into functional lobes, right and left lobes.
What are the structures which support the liver?
The liver is supported by the falciparum ligament, that is to the anterior abdominal wall and to the diaphragm. Then it is also supplied by the coronary and the triangular ligaments, which is from the liver to the diaphragm, and the lesser omentum, which is from the liver to the first part of duodenum and the stomach.
Okay, why the bare area of the liver is called the bare area? What is it? What does it? What is
because
it
there is
related
no
to?
peritoneum reflecting over it, and that is.
That's right. Okay, good. So, right. What is the relation of the visceral surface of the liver? What organs come in relation to it?
Ma'am, on the left side, it is yes, ma'am. On the left side, it is related to the stomach, and there is also a group for esophagus. Then on the right side, there is a colonic impression anteriorly, and suprarenal and a renal impression on the posterior part.
Okay. Can you please tell me this structure 9? You identified it as gallbladder. What are the parts of the gallbladder?
The parts of the gallbladder are body, fundus, and neck of gallbladder.
Okay. Can you please tell me the blood supply of the gallbladder, both arterial and venous?
The gallbladder is yes, ma'am. The gallbladder is supplied by the cystic artery, which is more commonly a branch of the right hepatic artery, and the venous drainage is accompanying the cystic artery.
Okay. What is Porta Hepatis? Can you point out which number is it?
Ma'am, yes, ma'am. Porta Hepatis is number 20, 11, and 5. Basically, it is structures included in the structure 23, that is the free edge of the lesser omentum covering the Porta Hepatis.
Okay. What's the significance of this structure?
Hello?
What is the significance of it?
And the Porta Hepatis, it runs in the anterior border of the lesser omentum. It contains the common hepatic duct and the hepatic artery anteriorly and the portal vein posteriorly.
Yes, but this is the anatomical orientation of the structures. But what is the significance? Why is it called
Yes,
Porta Hepatis, or why is it called? What's the purpose of having it in the free edge of the peritoneum or omentum?
yes, ma'am. So it during so we can during the procedures of the liver, when we want to stop the blood flow towards the liver, we can perform a Pringles maneuver by which we
Yes.
can apply pressure anteriorly and posteriorly to the Porta Hepatis. This can stop the bleeding if there is a bleeding during the operation.
Okay, good. Right. Can you right? There are also. Did you tell the lobes, caudate and quadrate lobes? Can you identify which part? Where are these?
The quadrate
20.
lobe is number 21.
Yes. Is
Yes,
it
ma'am.
part of the right
Quadrate
liver?
lobe is 21 and quadrate lobe is number 2.
Two. All right. These are part of left liver, left lobe of liver, or the right
Yes,
lobe
ma'am.
of
Quadrate lobe is
both?
the quadrate lobe is the part of the left liver.
Yes. I'm in a strange problem. My things are not working. Okay. Right. What more I can ask you? Can you tell me the development of the liver?
Sorry, ma'am.
Development of the liver. It develops
Yes,
from.
ma'am. Liver is developed during the 3rd and 4th week in wheat. It develops from the ventral. Hello.
Yes. Yes.
Yes, it develops from the distal foregut.
Okay. My network is bad, or I can't hear you properly. Can you identify the structures that you're looking at? What is the image that you're looking at?
Ma'am, this image shows a magnetic resonance magnetic resonance pancreatic cholangiogram. The structure A is the gallbladder, B being the right hepatic duct, C the left hepatic duct, and E is the common bile duct. Structure D is the renal pelvis showing the contrast enhancement.
Okay, what are the common conditions occurring in the associated with the liver or hepatic? What are the common conditions or what is the common type of carcinoma of the liver?
Hepatocellular is adenocarcinoma.
Okay, what are the, if you can tell me, if you can classify and tell me the classification of the hepatocellular carcinomas or hepatic lesions or hepatic conditions? Could be infective, could be benign or malignant. No.
Benign or malignant. In benign, it could be of epithelial origin like liver cell adenoma. Non-epithelial can be hemangioma, and adenomas could be like follicular nodular hyperplasia and mesenchymal adenomas. Then malignant, it could be, if it is of epithelial origin, it could be hepatocellular carcinoma or hepatoblastoma. And again, non-epithelial, it can be hemangioepithelioma or angiosarcoma.
Okay. Just a second. Last, let me check if I've asked you all. Right. There is one little question that when a patient with cholecystitis, why patient with cholecystitis feels pain in the shoulder tip?
If the patient has cholecystitis, the inflammation of the gallbladder causes the inflammation of the diaphragm, and the phrenic nerve, which supplies the diaphragm, has a similar root value to the suprascapular nerve, which supplies the tip of the shoulder. Therefore, the pain is referred to the tip of the shoulder.
Okay, the common question that is, what are the branches of Ciliatron which happen to supply both liver and the stomach?
And the hepatic artery, which runs in the anterior part of the lesser omentum, supplies the stomach as well as the liver.
Okay, can you also tell me if a patient gets a stab injury in the epigastrium, so what are the organs which are more likely to be injured?
With the stab injury in the epigastrium, the left lobe of the liver and the stomach are most likely
More
to be get
commonly.
injured.
Okay, good. Yes, arterial supply you've told me. So basically what is in the identification is important, that you told me very nicely. And the rest of the questions you can. So good, thank you.
Yes, ma'am.
Yes. Okay. So if you have read and understood, considering good history taking station, kindly begin.
I'll enter the room. I'll wash my hands. Hello, I'm Dr. Karma, one of the surgical doctors out here. May I confirm your name and age, please?
Yes, Dr. Rohit.
My name is Sarah. I am 67 years old.
Hello, Sarah. Nice to meet you. So today I've been asked to interact with you and ask you a few questions about your condition. Are you okay with this?
Yes.
Thank you. So how can I help you today?
Doctor, I've been experiencing some kind of vigorous shaking after 2 episodes of like falling down. So that is what I'm concerned about.
Oh, okay. I'm so sorry to hear that. Can you tell me more about it? Like, when did you notice it first?
So I noticed it around 1 month ago. This was the first episode that happened.
Okay. And
I was at home at that moment.
you are at home. Okay. And what were you exactly doing at the during that time?
I think if I can remember it right, I was cooking at that moment and I suddenly felt this vigorous shake in my body and then I couldn't remember anything.
Okay. And when was the last time you had?
The last time would be around 1 week ago
You
was the last
experienced
episode,
this.
doctor.
Yes.
So you had, yes. And uh, and where you said you were in the kitchen, right?
Yes.
And did anyone notice it? Was someone around you when you were having that?
Not really. Nobody was around at that moment. My husband was in the house, but he didn't see the shakiness.
Okay. Did you fall or trip over slip over something?
I don't remember, doctor, but yes, I remember falling down, but I don't remember.
Okay. So before you had this shaking and then before you fell down, did you feel anything, any like a different unpleasant sensation, or you had like feeling of anxiousness or fear?
There was some kind of a feeling before I got that.
Okay, you had some unpleasant feeling. Okay.
Yes,
And
yes.
how about when you fell down, you were unconscious?
Yes, I wasn't in my conscious. I don't remember anything after getting up.
Can you tell me for how long, if anyone?
Probably 10 minutes.
Okay. And so you said no one was there, so maybe you cannot describe what actually happened to you, right?
Yes, yes, doctor.
Okay. After, did you have like a tongue bite or hit your head or soil yourself?
I do remember that I had a tongue bite after that incident, but nothing more, nothing else.
Oh, okay, I'm so sorry to hear that. Okay. And after uh, that episode, like uh, when you regained your consciousness, how did you feel? Like, did you feel like drowsy, or you feel confused?
I did feel a little confused because I couldn't remember anything that happened.
And you felt that you were unable to speak, or you had some kind of muscle ache?
No, nothing like that.
Okay. That was it was more specific, I mean more prominent in the daytime or nighttime. Any diurnal variation?
No, nothing like that.
No. Okay. Anything like any drug, any medicine you had, or any fever?
No, doctor, nothing
Okay.
like that.
Did you have any neurological history, like trauma to your head, or any history of brain tumor that you were investigated for?
No, doctor, nothing of that sort, nothing.
No history of headache, or like if you feel like vomiting,
Mm,
disturbances?
Apart from the right which was shaking during the seizure, I don't think any other problem.
Okay, so it was your right arm that was shaking.
Yes, yes, sir.
Okay, okay. And any surgery in the past?
No, doctor.
Some questions, if it's okay with you.
Yes, definitely.
Any history of any family members having similar condition?
None, doctor.
Okay. What do you do for a living?
I am at home wife. I used to work as a teacher at a school, doctor.
Okay. Okay. And do you drink or smoke?
No, doctor.
Okay. So you
Can
have
you
this
summarize
problem with
your
you. What do you
history
think
now?
would have caused this to you, and what are your major concerns?
Can you summarize your history now?
Yes. Thank you. Thank you, Miss. Thank you, Miss. Thank you for your time. If time would have permitted, I would like to complete the ICE and
Yes.
systemic review.
Yes.
I have taken history from Sarah, 67 years old elderly lady,
Yes.
who had a history of 2 episodes of seizure. One episode was 1 month back, and then the second was last week. The she had the aura before the seizure, and the
Okay.
seizure was focal in nature. She stated that she had shaking of right hand, right arm only, and also tongue bite.
All right.
After
So what are your differential
she also has some drowsy and confused.
Yes.
From my history, I would like to consider it as a focal seizure, because
Okay.
there was a focal seizure, and I'd also like to consider general tonic-clonic seizure, but
Yes.
there was no history supporting that.
No previous history. Yes.
Uh,
What investigations would you ask for to confirm your diagnosis?
the investigation I would like to run is I would like to do a full blood count, urea and electrolytes, serum calcium and magnesium with blood glucose level, ABG. I would like to do some scans, CT scan and MRI, also do an EEG, and do some EEG.
What treatment can you offer to the patient for this condition?
If the patient is actively seizing, then I will manage according to the CRISP protocol. I'll move the patient to safe place, put him on a recovery position, and then consider giving him benzodiazepine or anti-epileptics. After the seizure, I can start him on benzodiazepines and anti-epileptics. And if he has a history of, if there's any history suggestive of status epilepticus, then I can start manage him according to the CRISP protocol, and then managing the ABCDE approach. Give him oxygen, consider intubation, and then start on benzodiazepines and anti-epileptics.
All right, good. So if Dr. Rohit can give feedback, please.
Yes, ma'am. Thank you, Dr. Karma. I think he covered almost all the questions,
Yes.
and which he did not. He summarized, ma'am. I can only remember of one question he did not ask in history. That was the eye deviation and the eye blinking, so that we can find out which lobe is involved. That is the only
Okay.
question I can remember, ma'am.
Did you ask about any drug history?
No, ma'am. That part was left because he could not ask me about the drug medical history and that.
Yeah.
So he
The
summarized
family
that.
history. Family history also he has made.
He asked family history, I guess. Does anybody in my family have the same
Okay.
thing?
Yes. 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 All right.
I
good.
did ask about the medical history with the fever.
Yes, ma'am. He did ask
Medical
about the
history you
fever.
did, yes.
Yes.
But not the drug history. Yes.
Ma'am, since he said there was no one, beside him, I could not ask what actually he had, what actually
She.
about his head, eyes,
Patient was the
lips.
girl. Yes.
So sorry, she. So I could have asked those things if someone was around him.
Around her.
Sorry, her.
Who had witnessed. Yes. Yes. But
Yeah.
then this was the second episode. You made sure patient did not have the history of trauma at the time of event. But then, do you think this is seizure, but it's not epilepsy? So what is the most likely diagnosis in this condition?
The history suggests of focal seizure, ma'am. Then it could be most probably some brain tumors like frontal tumors.
Yes. That's what I wanted you to
And
focus
considering the
on.
age, can it be a cerebral?
True, could be, yes. But it's not epilepsy. This is what I wanted you to focus on. Good.
Yes, ma'am. It's not epilepsy.
It's not epilepsy. Good, thank you. Started your timer and here is your question.
Ma'am?
Yes.
Yeah, this is about epidural block. The station was about epidural hematoma. I can go with it, but I haven't read it in the recent past.
Your timer and here is your question. Right, so if you have read and understood, considering the critical care scenario, kindly tell me how would you manage this patient now?
Yes, madam, this is a trauma patient. It needs to be managed according to ATLS protocol.
Yes.
That involves with A, that is airway. Patient has a GCS of 8 and will require aggressive management of his airway, probably needing an endotracheal intubation. Second thing is breathing. Look for breathing, any other problem like decreased breath sounds or pneumothorax that needs to be handled. And C comes the circulation. I will pass IV cannulas and look into the blood pressure and circulation of patient. Probably will give him IV fluids.
All right, just suppose patient is comatose, so you decide to take care of the ventilation of the patient. How would you prepare or how would you do the settings of the ventilator? Or what
Yes,
would
this
you
patient, considering that he has a brain injury,
do? Yes.
we will keep it on the hyper. We will try to be on the lower side of the carbon dioxide.
How?
The desired level of carbon dioxide should be 35 millimeter of mercury or 4 kilopascal. This will help us in causing a vasoconstriction that
Yes.
will reduce the intracranial pressure.
And it will control the degree of intracranial vasodilatation as well.
Yes, this is a temporizing
Yes.
measure.
Yes. Okay. Can you please tell me when the patient arrived, patient had Glasgow coma scale of 15 and after vomiting twice within 15 minutes, it was noted to be 8. Why? What has happened?
Yes, this is classical presentation of extradural hematoma, and this period of consciousness is called lucid interval. This is because the brain has a compensatory mechanism to accommodate the increased intracranial pressure till it rises to a certain level where no more compensation is possible.
Okay. Can you please tell me, is there a way with which you can normally measure the intracranial pressure?
Yes, ma'am, there are invasive as well as non-invasive measures. The non-invasive
Yes.
measures are not as accurate as invasive measures. Non-invasive measures include tympanic membrane vibration assessment and transcranial ultrasound to see the middle cerebral artery pressures. The invasive measures include invasive intraventricular pressure measurements, intrathecal, subarachnoid, and extradural measurements.
Okay.
These are all invasive measures with different level of risk and complications.
Right. Considering patient has increased intracranial pressure, what is the danger of doing lumbar puncture?
Yes, if the patient has raised intracranial pressure, it could cause tonsillar herniation.
Yes, herniation and hernia. Okay, can you please tell me how would you differentiate between Cushing reflex and the Cushing triad?
Cushing reflex is something that patient is having a bradycardia as well as hypertension. Because of the hypovolemia, the brain has ischemia, so it has increased the sympathetic supply to the body. This increased sympathetic supply causes a high blood pressure. Once the blood pressure rises, it stimulates the baroreceptor at carotid body. And once these baroreceptors are stimulated through a reflex, they cause a bradycardia. This is called the Cushing reflex.
Answer
This
has
is called.
gone, yes, out of the track. All right, can you please tell me the pathophysiology of the increased intracranial pressure? What do you understand by the Monro-Kelly hypothesis?
Yes, Monro-Kelly hypothesis is that brain is a bony cavity that cannot expand. So the contents need to be fixed.
Three components.
Yes, the
Please tell me
80%
about.
is the brain tissue, 10% is blood, and 10% is CSF.
Yes.
So any rise in brain tissue like space occupying lesion or any hematoma has to be sacrificed on the cost of the blood or CSF. Up to one point, it can be compensated. After that point, once it's not compensated, then the ICP will rise steeply and causing symptoms of raised intracranial pressure and brain herniation.
If you do the CT scan on this patient, how do you expect it to be, or what do you expect it to find? On
Yes,
CT
most
scan?
likely it will be a biconvex hyperdense shadow that will be abutting between the periosteum on the interior side and the dura on the other side. So we can see there is shifting of the midline, compression of the ventricle. Yes, these are the main findings.
Okay. Can you please tell me how would you take care of what medications or what management would you give to the patient?
Yes, if the patient has
increased intracranial pressure. Yes.
Yes, this patient has a GCS of 8 and he will require immediate neurosurgical transfer and intervention. But as temporizing measure, we can do osmotic diuresis that can use mannitol, hypertonic saline, or furosemide to
How much
induce a
mannitol
diuresis.
would you give?
The dose is 0.5 to 1 gram per kg. And it needs to be infused in a period of 30 minutes.
All right. Right. If you are asked to do a borehole in this patient over Ciliatron, can you please tell me what are the layers that you'll go through from outside to inside? Yes.
It will be skin, dense connective tissue, plia aponeurotica, loose connective tissue, temporalis fascia, temporalis muscle, and periosteum. Once through the bone, we will be at the extradural surface where we can drain the blood, the hematoma.
All right. Can you please tell me what are the factors that you'll consider for intubating the patient?
Yes, it's the level of consciousness. If its GCS is less than 8, or if there is a possibility that patient will require intubation, like an inhalational injury or a facial injury that is actively bleeding or a laryngeal fracture. And apart from this, Other indications for intubation are increased work of breathing if the patient has impending respiratory failure.
Yes. Okay.
And, yes.
How would you take care of the nutritional status of the patient, of this particular patient?
Yes, patient might develop curling reflex because of increased gastric acid secretion, and we need to protect him with the proton pump inhibitor therapy. Apart from this, if the patient has reduced gastric emptying, we need to do enteral nutrition, that is through the gastrojejunal tube. If the patient cannot tolerate the stomach
Yes.
tube, and yeah,
What are
both
the
are
complications that you will keep in your mind when you're taking care of the fluid requirement or the nutritional need of the patient?
his patient might develop tube-related complications as well as feed-related complications. Tube-related complications are irritations, gag reflex, ulcerations, and feed-related complications may include hypo or hyperglycemia, diarrhea, and fat fever, and
Yes.
electrolyte imbalance.
And cerebral edema can, as a
Mm.
result, occur.
Yes.
Okay. Right. Can you tell me what are the conditions when you must ask for a CT scan earlier than later? in a
Yes,
patient
there
or
is Canadian CT scan criteria that involves the signs that patient might have. This include episodes of true vomiting,
Yes.
GCS less than 15 for more than 2 hours, and the patients that are aged more than 65 or on anticoagulants, and there is depressed or open skull fracture, and if the patient has signs of the base of skull fracture like raccoon eyes, battle sign, and CSF rhinorrhea or hemotympanic. And these are the main indications where immediately you need to go for CT scan.
Good. Nice. Yes.
Thank you, ma'am.
Today I enjoyed. It
Yeah.
was nicely prepared. Good. Thank you. And I have started your timer, and here is your question.
Ma'am, I think Dr. Mohammed just exited his
disconnected.
network.
Yeah.
Yes, ma'am.
I'll-
Yes, we
Oh.
can.
Okay.
Right. Did you get to read the question?
No.
Okay, it doesn't matter. Read now and then let me know.
Okay.
Yes. So if you have read and understood, considering this history taking station, kindly begin.
Hello, I'm Dr. Muhammad, one of the exam surgical candidate. Today I've been asked to ask you some questions related to your condition. Are you okay with that?
Good.
Yeah, it's fine. It's fine.
Thank you. May I confirm your name and age, please?
Yeah, Susie. I'm 54 years.
Nice to meet you, Susie. How can I help you today?
Yeah, doctor, I have a backache. It's been here for the past 5 years and it's been worsening.
I'm really so sorry to hear that. When did you first notice that?
Yeah, the pain started about 5 years ago. And then the past 3 years, it's really bad. It's really bad. Sometimes I can't sleep at night.
I'm really so sorry to hear that. Did it start suddenly or gradually?
Yeah, it started gradually.
Okay, can you point status to pain, please?
Yeah, around my lower back.
Okay, can you describe the pain for me? Is it colicky? or cramping or aching in
Yeah, it's
nature?
just aching, doctor.
Okay. Is there a specific time during the day which might be increasing or decrease?
Yeah, especially when I wake up in the morning and then I'm about to start work, it's difficult to even sit up because of the pain. And then when I get stressed during the day, do a lot of work, so it gets worse.
Okay. Is there anything which makes the pain increase or stop?
Yeah, when I do a lot of work, it's worse. But when the pain stops when I am resting or when I take some drugs, analgesics to ease the
Okay.
pain.
If you would rate the pain from 1 to 10, with 10 is the worst imaginable, how would you rate it?
On the bad days, it's about 7. On certain normal days, maybe 3 to 4.
I'm really sorry to hear that. Do you want me to give you any kind of analgesic?
No, today is a 4 day, so I'm fine.
Okay, how does it affect your day-to-day life?
Oh, well, I have to take care of my husband, and he's disabled. I have to use my back a lot, carry him to the bathroom and all that. So the back pain really limits me from helping him, and I don't have so much money, so I can hire in and I help for him. So it's really,
I'm
really, I
sorry
need this
for that.
pain. It's fine.
Really sorry to hear that.
That's okay.
It the pains go down to your buttocks or legs?
No, none of those.
Do you have any weakness in your legs or numbness?
No,
Any abnormal sensation do you have?
no, none of those.
Okay. Do you have any problems when passing water or stool? Hello?
No. Maybe he got disconnected.
Okay.
Yeah, I can help him.
Yes, Dr. Maimon is helping. Continue, please.
Thank you. Do you have any problem when you pass in water or stool?
No,
Okay. Do you have any fever or night sweat?
no,
Do you have any history of cough?
not exactly.
Hello.
Yes.
Yes. Hello. Do you have noticed any swelling in your neck?
No,
Okay. Do you have any stiffness in your back in the morning?
sometimes I feel, but not exactly.
Okay. How long did it last? About how many?
It lasts like more than 1 hour,
Okay, I'm sorry to hear that.
but I feel it's not stiffness, it's just a pain.
Okay. Do you have any history of trauma to your back?
No,
Okay. Do you have any history of fracture that was caused by little history of trauma?
no,
Okay. Do you have any pain in your tummy?
no.
Okay. Do you often see your GP for any other medical condition?
Yes, I am hypertensive and I take
Mhm.
medication for that.
Okay. Do you know what type of medication and how long do you have been hypertensive?
It's been 5 years I'm taking this medicine. It's so fast.
Okay. Have you underwent any surgery before?
I had one cesarean section 5 years ago.
Okay. Do you have any long-term medications or are you allergic to any drugs?
No,
Okay. Do you mind if I ask you some personal question, please?
yeah, sure.
What's your occupation?
Well, currently I'm not working because of
Okay.
my husband. He depends on me, so I have to take care of him.
Okay. Who is at home with you? Is your husband just, or is there anyone else?
My grandmother as well.
Okay. Do you smoke or drink alcohol?
Yes, I smoke, but I don't drink.
Okay. How many packs per day, and for how long?
Well, one pack per day, I can, and it's been around 20 years now.
20 years. Okay. So what do you think is the cause?
I don't know, doctor. Maybe it's because I have to, carry a weight, or
Mm-hmm.
I am helping my husband as well as my grandmother. So maybe because of that as well.
Okay. What is your biggest concern?
Well, it's getting worse day by day, and it's difficult for me to, to do my daily chores. Yeah.
Okay. What do you expect us to do for you?
Well, doctor, I am expecting you to treat me as early as possible. I can't bear this pain anymore.
Okay, I will
and
sure
it is
to.
yes, your history now, please.
Before I present, if time would allow me, I would like to complete my history by asking about systemic review.
Yes.
This is a 44 years old female who has history of back pain 5 years ago.
Yes.
Now 3 years ago has been worsening. It started gradually at the site of lower back and increasing when wake up. And also she is hypertensive about 5 years ago, and she has history of cesarean sections. And she also she's smoker about
Yes.
20 years ago, 1 pack per day.
So what are your differential diagnoses for this patient?
My first differential diagnosis will be functional or mechanical back
Yes.
pain,
Yes.
and also can be due to intervertebral disc prolapse,
Yes.
and can be due to ankylosing spondylitis, and also can be due to osteoporosis or trauma.
Yes. What investigations would you ask for to confirm your diagnosis?
Okay, after taking history, I will examine the back of the patient, and also I will do lower limb examination. After that, I will order some investigation like routine CBC, urea nuclide, ESR, and C-reactive protein.
Yes.
And also I will ask for MRI or CT scan.
Good. So can you tell me the treatment option that you can offer to the patient?
Okay, for this patient, first I will go for conservative management,
Yes.
like avoid lifting heavy objects, and also avoid prolonged bed rest, and encourage exercise. And also I will prescribe some muscle relaxant. If it is other cause, patient might be need surgery if it's prolapse or cold equine syndrome.
Okay. What are the red flags that you look out for if it had to be correct syndrome?
Okay, a red flag, this is a sign of cold equine syndrome. This is if patient age is more than 50 or less than 20. If there is any symptoms like paresthesia and also pain at the legs, and also history of osteoporosis, and it's also history of trauma.
All right. So what's the treatment in that case?
Surgery,
Yes.
typically comparative. Yes.
Yes. Urgent. Good. In this case, one small thing for the management, that you'll also refer the patient to the social worker.
Social worker, yes.
Yes. So this is the only little thing that you forgot. So good. Now can the people who were helping Dr. Mohammed can give feedback? Dr. Maimuna and Dr. Abbas? It was good, Dr. Mohammed.
Thank you.
I have one thing.
Yes, please.
I didn't prepare this the station, but I in the past I read it. But I think there is the importance of like asking okay, do you have pain in the going upstairs, or the pain released by cycling? There was the disease,
Yes.
some
Yes.
differentials. I didn't like remember exactly what was it.
Yes,
Because
Dr. Mohammed will
sorry, I
tell you.
didn't.
Yes, Dr.
Yeah.
Mohammed, if there is spinal canal stenosis, how would you
Yes.
how
Yes,
would you diagnose it?
the
What is the
patient
diagnosing question? Yes, please. This is what she wants to know.
pain will increase when patient goes down to stairs, not up down. I
Downstairs.
think.
Yes.
Yes.
It relieves when you're bending forward, like when you're climbing
Yes.
upstairs. So this is the diagnosing factor,
Or
diagnosing.
canal stenosis.
Yes. 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 Yes, Dr. Bas, can you give feedback to Dr. Mohammed?
Yes, ma'am. Dr. Mohammed did a very good job, ma'am.
Yes.
Sorry, my network was a bit bad,
That's
but
all
I
right.
think he
It's
did a very
overall.
good job.
Yes.
Yes, ma'am. He did a very good job, and
Yes.
I just want to say that he should just continue practicing the history this way. I'm sure he will be able to cover most of the parts. Then,
Definitely.
however, I think he should try and the way he asked for his ICE history is good, but his ideas what didn't come out too clearly. It seemed he was just asking the patient if she knows her diagnosis, but it's better to say, what do you think, or what ideas do you have? Make it clear to the examiner that you are asking for ideas, concerns, expectations, because so you don't want to leave any chances for them to score you low. There's some examiners, they will tell you didn't ask for ideas, you only ask for asking the patient for her diagnosis. Then the other thing I would like to say is, yes, ma'am. Then the other thing I would like you to say, considering you've covered everything, is at the end of your history, before your time runs out, is to ask the patient, is there anything else you want me to know?
Yes, he didn't get that.
Because
that
particular thing will help, just in case you forgot something. That way, they will tell you.
Yes. Yes. This
Yes,
is when you
ma'am.
get to
And
that
another
level.
important thing in the communication. Yes, ma'am. And then another thing important in the communication stations, history and communication skills, is that while you've asked your question, say for example, you've asked, maybe when you've done the pain score, and then you ask the patient, okay, you said your patient, okay, maybe the patient told you, okay, my pain score is 4, the score is 4, and then it's about a 4, and then, or it tells you, okay, I have to take care of my husband. So maybe after you've asked 1 or 2 questions, you can say, okay, so you've told me that your husband, you have a severe back pain and you have to take care of your husband. I'm so sorry about that. Just to register the fact that you've been listening to the patient and you've registered what he has said. Because there's another person that has five whole marks with him or her. That's the person that is not the doctor, and the person is always in history and communication skills station. So those people, they want you to, if you've done OET or IELTS, there's the listening station where they want to assess your listening skills to the patient. So your listening skills is not just to hear, you have to also give feedback to the patient. Yes, ma'am, acknowledge you've heard. So those are some of the things they test. So it's important. 1 or 2 marks can be gotten from there. That's just my contribution. Thank you.
Thank you so much. Good.
Okay. Thank you, Dr. Abbas.
Thank you. All of you.